Welcome to another episode of the MEGIN Spotlight series. We are delighted to have Professor Srikantan Nagarajan join us on the Spotlight today. Professor Nagarajan is a professor in the Department of Radiology and Biomedical Imaging at the University of California in San Francisco. UCSF is a very prestigious institution, ranked #2 in the USA for neurology and neurosurgery by the Best Hospitals US News World Report. UCSF has both comprehensive programs for brain tumor and epilepsy care with state-of-the-art neuroimaging modalities, including MEG. Welcome to the program, Professor Nagarajan.
Thank you. Glad to be here.
So let's start with the first question. Can you please tell our audience a bit more about your background and how you became exposed to and now passionate about MEG technology?
Thank you. Yeah, I'm trained as an electrical engineer and a biomedical engineer. I got my PhD in biomedical engineering, and I actually worked on magnetic stimulation for my PhD work. And when I came to UCSF for my postdoc, which is when I actually was first exposed to MEG. It was actually through a dear friend, colleague, Dr. Kensuke Sekihara, that we started a collaboration that lasted for 3 decades, working on signal processing algorithms and machine learning algorithms for MEG. And since then, I've been involved and associated with MEG, pushing the technology and its applications.
And we know you utilize MEG in the brain tumor treatment program at UCSF. And could you let us know how MEG is incorporated into the operational flow of the program? And at what point might a patient receive a MEG scan and how this might inform the clinical decision-making?
Thank you. Yeah, so we, unlike many other clinical sites at UCSF, we half of our clinical workload is taking care of patients with brain tumors. So typically we do basically neurosurgical planning. That's kind of what we use MEG for. So a patient who's getting surgery, they come to UCSF from all over the world for brain tumor surgeries. And prior to their surgery, they get preoperative imaging workup, and MEG is now an integral part of this preoperative imaging workup. And the way we incorporate MEG in this workup is we provide basically functional information about important landmark brain regions, like say hand motor cortex, face motor cortex, face somatosensory cortex, and auditory cortex, and visual cortex. So these kind of important functional landmarks are the first steps that we provide in terms of the preoperative imaging workflow. So these patients typically come in and get scanned about 2 days prior to surgery. And we do all our assessments and provide that in the surgical navigation suite software. So the surgeon always looks at our technical reports prior to surgery and has the MEG information available even during surgery through the neuronavigational software suite.
Oh, that's great. And then for other institutions who have an operating MEG but may not be integrating this into the tumor program, such as UCSF, what advice would you give them, or how about to start utilizing MEG for functional brain mapping?
Yeah, I think the success of a MEG tumor program is really contingent upon 2 counterparts. One is a very interested neurosurgeon, a brain tumor surgeon who's sort of interested in MEG and interested in integrating the information from MEG in their surgical planning and surgery. So usually that's very important to have build a relationship with a tumor surgeon for whom this information can be valuable and provided. And of course, it also requires MEG scientists who can sort of deliver this information in a timely fashion. So as I said, the tumor program requires these sort of really fast turnaround for MEG acquisition to analysis. And you have to have a team in place for providing that kind of service.
Yeah, we sometimes hear from patients and physicians that it can take a long time to receive a comprehensive report from the MEG lab once a patient has been scanned. And you've just mentioned it earlier. Can you give us an idea on the complexities of MEG data analysis in the programs at UCSF, and how do you overcome this? What are your average response times in regard to patient reports in both, I guess, epilepsy and brain tumor programs?
Yeah, the turnaround time for MEG reports are very different for tumor and epilepsy. As I mentioned, in tumor, it's often, in the case of brain tumors, we have this sort of very quick turnaround, often less than 24 hours, maybe 48 hours at most. In terms of if, say, a patient gets scanned on a Friday and they get surgery on Monday, we have the whole weekend, but that's a luxury. Often we have a patient scanned on a Sunday and they go into surgery Monday morning, and we have to have staff in place to do all the analysis. In the case of functional mapping for brain tumor, the analysis is fairly automated. You need to, identify it just depends on the scan protocols. And we do at UCSF, we do many scan protocols. We do somatosensory mapping, motor mapping, auditory mapping, language mapping, resting state connectivity mapping, and so on. So that's what takes time, is the number of scan protocols we administer and doing the analysis for all of them.
Okay.
It's a very different ball game in the sphere of epilepsy. So MEG in epilepsy in tertiary medical centers like UCSF are often the most complicated cases. So this is where they've had their primary EEG scans, long-term EEG scans, and or they may have had prior VNS, and then but their intractable epilepsy is still not under control, so they're being evaluated for epilepsy surgery, and that's when they get usually their MEG. And so these cases are more complicated. They're not your simple, here's a temporal lobe epilepsy, or here's a very clear seizure onset zone. So often the epilepsy team is really grappling to trying to figure out where are the candidate locations for doing surgical resection in these patients. So given that complexity, often that's what drives the length of the report, because we record an interictal window. So we record about an hour of data in a patient with epilepsy, unlike long-term EEG, where they're waiting for a patient to have a seizure. So in this hour, patients rarely have a seizure. And we, in 20 years of our operations, we've had about 24 patients who have had seizures in the scanner. So mostly we're looking at an interictal window, and we want patients to fall asleep in the scanner so that we can get more, epileptiform activity that we can pick up with MEG. So what's involved is often about 45 minutes of data storage that we have to go through every 100 milliseconds. So we have to scroll this data. So that requires manually. And what we're doing is identifying epileptiform events. And that requires expertise. Again, an MEG tech or an epileptologist who's used to scrolling MEG data and picking out abnormal events. So first pass, they would just scroll the data to look for what they call normal background activity and benign forms, and so that they can identify the abnormal epileptiform activity in the presence of this sort of normative background. This is perhaps in a few years, this might be automated with machine learning, but it is not. Currently, it is very human expert intensive process. So once you identify these events, then you have to localize them, which is using source localization algorithms to ask where in the brain are these events coming from, and then you have to kind of interpret where do those brain locations, are they artifactual source localization, or is that reasonable? Is it meaningful? Is it consistent in the record? And is it also consistent with the semiology? And then you have, that's what goes into the report that is generated as a result of the epilepsy scan. So this can take sometimes several weeks because it requires multiple passes on the data, where the epileptologist might, or the technologist might screen, identify events, source localize, identify them, and go through with an epileptologist who might say, well, these look okay, but maybe these are not okay, and you need to identify more such events. And so it might be like or a patient or the technologist might go through and find maybe no spike, and then they might actually go through again to find like one spike or two spikes because they're just grappling at straws to find something, some abnormality that could be useful to guide the comprehensive epilepsy team. So given that, our goal at UCSF, we would like to have reports done in a week, and that's still an asymptotic target for us. We typically have a turnaround about 2 weeks, but in the most complicated cases, it can take up to 6 weeks.
And that's based on this what amount of staffing? I mean, what does the staffing look like in the team, I guess, for that?
Yeah, well, again, the staffing is very different for epilepsy versus brain tumor. And then there's a little additional thing that we do at UCSF, which is, I think, also perhaps a lesson for a lot of MEG centers, is that the brain tumors protocol is for functional mapping. It's really a neurosurgical guidance, pre-surgical planning software that we provide, information that we provide. In epilepsy, they're also being evaluated for surgery. So if, in fact, our epilepsy patients get the epilepsy protocol and they also get the functional mapping protocol.
Okay.
So the epilepsy protocol that we do includes the brain tumor functional mapping. So the staffing for functional mapping is very different from the staffing for epilepsy. Your minimal staffing for epilepsy, as I said, involves an expert MEG technologist who would identify these events and works with the existing software pipelines to figure out where in the brain they're coming from and generates a preliminary technical report of here are events that I identified. These events might be artifactual. These events might be real. So it has then that requires an oversight by a clinical epileptologist who can then look at them and be able to say, no, that looks like a benign form, or that's an irrelevant spike. This is the one that you have to focus on. And there's an iteration between them to generate the clinical report. And the clinical report actually has 3 components, I would say. One is a neurophysiological read, which is often needed by referrals. So they need to say, okay, I have seen this in this patient. I have had a low-res EEG or a long-term EEG, and I've seen this. I'm not sure where in the brain it's coming from. I'm not even sure if it's relevant. What do you guys think? That would be a question a referral would ask us. And so we have to say, let's address the neurophysiological read and say, do we see that, or what do we see? What do we see in EEG that we don't see in MEG, or vice versa? What do we see in MEG that we don't see in EEG, and those kinds of things? So that's a neurophysiological read. And then the second part is the source localization that corresponds to the neurophysiological read. So the neurophysiological read, say, maybe identifies certain interictal spikes or sharp waves or spike and sharp wave complexes. And we need to say where in the brain that's coming from, and is that relevant given the semiology of the patient. So the third component is what we have, a neuroradiological read, which is to say, given the source localization and given information that a neuroradiologist sees in MR or SPECT, do those things provide concordant information that would help the comprehensive epilepsy team? So the staffing requires an MEG technologist, an epileptologist, who will provide both the neurophysiological read and the source localization, and the MEG technologist would also help with the software pipeline, and a neuroradiologist who would provide the final clinical report.
Okay.
That's on the staffing for the epilepsy side. The staffing for the brain tumor side, as I said, requires this exigent turnaround time. So there you have an MEG technologist who would be doing the scanning, and maybe a team. We are usually nowadays, we find that it's very efficient if we have a team of 2 or 3 people who work on the technical report generation. So they would basically analyze the data as it comes in. So there's one person on the console working with the patient and the scanner as the data comes in. And then there's a second person who's doing the pre-processing, and perhaps a third person who's basically doing the post-processing analysis to generate the technical report. So that way, we can turn this around. This is not necessary. I think one person can do this. It's just that one person doing it means that that person is scanning, doing the pre-processing, doing the analysis for technical report generation, and generates a report. That can take a 12-hour day for a person because given the number of protocols. So we have a team of people on that side. And then that goes to often a wet read that's given to the surgeon and a neuroradiologist who would interpret that on our side. some MEG centers have neurologists who would do the reads and the final report. In our case, we are in the Department of Radiology and Biomedical Imaging, so our readouts are with the neuroradiologists.
Okay, thank you. Going back to another question then, would you be able to share an example or two where MEG has made a difference in the treatment planning and clinical decision-making of a brain tumor case?
Yeah, so in the case of brain tumor, I can think of several examples. Every bit of information that we provide to the neurosurgeon, we've queried our neurosurgeons about, is there any information that you feel is irrelevant? And they say, no, we want to see all of the functional mapping information before we go and plan surgery. So in addition to sort of I would say there are three components to our brain tumor protocol. One is basically the functional mapping of somatomotor auditory cortex. So that's sort of a basic paradigm that tells us, okay, here's central sulcus, here's lateral sulcus, and if there's need for visual cortex, we also provide that. So that's sort of the baseline information that we provide with somato and motor. The second bit that we do which has actually been very useful is language lateralization localization. So the gold standard, of course, is the WADA test, but a lot of places they either don't have the time or they don't see a need, or it's an extra complication to do a WADA test. So MEG provides nice information about the language lateralization. So here is where information can be very useful. So you have a patient, let's say a left-handed patient with a right-sided tumor. And so often the big question is, should the tumor surgeon do awake surgery or a sleep surgery? If they think that the tumor is in the hemisphere that's dominant for language, then they would do awake surgery, meaning during surgery, they would wake the patient up and then do language tests and do mapping in and around the tumor to ensure that they're not taking out or resecting critical parts of the brain that are important for language function. Okay. On the other hand, if it's a non-dominant hemisphere, then they might do the surgery asleep and just resect the tumor without having to be worried about disrupting language function. So we've had several cases where left-handed patient, right side tumor, we provide and say, this is unequivocally a left dominant patient. So the surgeon will basically say, then that's great. I will do a sleep surgery versus awake surgery. And there are differences in complications, the length of the surgery. And this is, I would say, one of the biggest impacts we've done. There's a third part to our protocol that surgeons also use. We provide information about the functional connectivity of the tumor. And we've shown that the functional connectivity of a tumor can predict intraoperative mapping and also can predict postoperative outcomes. The proximal prediction is the intraoperative mapping. So we've shown that we have very high negative predictive value for intraoperative mapping. So this is actually used because when a surgeon in awake surgery, I mentioned that surgeons open the brain, before resection, they do awake language mapping. And part of what they do is what they call intracortical electrical stimulation mapping. So they wake a patient up in the surgery and make the patient do language tasks, stimulate different parts of the brain to see if any site, when you stimulate, it disrupts language function. If so, then they will deem that site to be very critical and be very careful in tailoring their surgery around those critical sites. Now, you can't map the entire brain. So you need to be able to be guided about where you do your mapping. And here's where MEG can really come in. And we've shown that if you get tumor that are highly functionally connected versus low functional connectivity, we found that tumors that are high functional connectivity, you can have intraoperative sites that are positive for language, not a great predictive value, but about 2/3 to 1/3. But if we have tumors that have very low functional connectivity, then the intraoperative stimulation will have a very low yield. Our negative predictive value for intraoperative cortical stimulation is very high, close to 90% or so, which means that if a surgeon finds that there are parts of the tumor that are low functional connectivity, they can sort of focus on the tumor voxels that have high functional connectivity for the intraoperative stimulation mapping. And this has implications in the length of surgery because it shortens the intracortical stimulation mapping that they have to do.
Well, thank you. That was amazing to hear that, with MEG that is possible. Something completely different now. A question that we get often is from a hospital administration perspective, how has UCSF achieved the ROI of having MEG technology as a standard in your program, epilepsy and brain tumor program? I mean, have you seen an increase in the number of scans in the last 5 to 10 years, and has that improved, I guess, the ROI of the technology for the hospital?
Yeah. So just to clarify, we're actually a campus-owned facility as opposed to UCSF hospital. We obviously our referrals for epilepsy comes from both UCSF patients as well as non-UCSF patients. Actually, the referral that we get for epilepsy, about only 1/3 of our patients are UCSF patients. The other 2/3 are non-UCSF patients, and they can be coming from anywhere in the Western US. We've had patients from Arizona, from Seattle, and all the way from Orange County and UCLA, because UCLA does not have an MEG, and so they send us their patients and so on. Yes. So there has been growth in our MEG scans. On the epilepsy side, a few years ago, we had a little bit of a asymptotic dip, but I think it's picked up again. And I would say we see about 100 to 100, anywhere between 100 to 150 patients a year for our epilepsy. On our tumor side, we see an equal number, or if not a higher number than that. So we might be one of the busiest clinical sites in the US or the world, because we see equal numbers of epilepsy and tumor patients. So our patients are, as I said, anywhere from 150 to 200 tumor patients in addition to our epilepsy. So that kind of is an increasing number. So, from an investment perspective, I think the back of the envelope calculation that somebody can do based on US payer base is that I think if you just focus on a clinical site for MEG, I think the back of the envelope calculation tells you that if you see about 100 patients purely for epilepsy, you'll be a break-even operation, perhaps a little better than break-even. Okay. And now if you add the tumor to that mix, that will tell you something about the return on investment.
Yeah, we hear that there's a wait list now on your side for patients from the Western from California and
Yeah, we are trying to minimize that. We've increased our staffing, and we're a 6-day operation, which also might be unique for us as an MEG site. So we work on Sundays as well for our tumors, mainly for the tumor side. Yeah. And we're trying to reduce our wait time for epilepsy to about 6 weeks. There's a little bit of a complexity in terms of the wait list. Let me just add one thing to say that when people get referral for MEG for epilepsy, say anywhere from an outside center, typically, when they're referred to, it's not one of the things that we need to ensure is that their MRI is already in place. And so one of the biggest holdups we have a set of patients where we're waiting to schedule them for MEG. And the reason we prefer that a MEG, when a patient gets an MEG scan, their MRI is already done. And so we can start the analysis because we need the MRI for source localization. So we prefer that because we can't do any source localization, so we can do event detection, but we need source localization to sort of prune events that are artifactual versus real. And so we always insist that we have good quality MRI, 3D MRI, before we scan our patients. And so this is often the biggest holdup, is that if MRI is in place, we can get a patient in very quickly. But often we have to wait for either an external MRI, or we have to coordinate if they have to get an MRI at UCSF. And that often can be a bottleneck.
Yeah, that makes sense. Amazing. Thank you. Apart from MEG used clinically at UCSF, how is it being used in emerging clinical translational research at UCSF?
Thank you. Yeah, I would say about, in addition to having a very robust clinical operation, we have many ongoing translational clinical studies across a variety of disorders. Perhaps the largest program that we have in terms of clinical translation research with MEG is in the area of dementia. So we have ongoing work in patients with Alzheimer's disease, patients with primary progressive aphasia, as well as frontotemporal dementias. So I think that one of the things we found recently is that in patients with Alzheimer's disease, there's a very high, about 40% of them, patients with Alzheimer's disease have subclinical abnormal epileptiform activity. And so we found that we can detect this with MEG, and we can localize it, and it's actually a continuous spectrum, and it's perhaps something about a phenotype of hyperexcitability in Alzheimer's disease that might set them up for progression, disease progression. So I think given that finding and a variety of other findings of value of MEG in Alzheimer's disease and dementia, I think that this could be perhaps the next clinical application for MEG, because MEG is already a very unique modality for assessment of epilepsy and epileptiform activity. And I would think that a patient with suspected Alzheimer's disease would want to get an assessment of whether they have subclinical epileptiform activity that could be potentially therapeutic targets. So this is an area of active research that we're doing, and I think it's very exciting that there's this sort of intersectionality, and it's an extension of what MEG can offer in epilepsy into the arena of dementia. We also have shown that the advanced source localization analysis can help us assess dementia disease progression, dementia trajectories in not only Alzheimer's disease, but also non-Alzheimer's disease, like primary progressive aphasias and frontotemporal dementias. The other area that we have participated in many ongoing work is everything from neurodevelopmental disorders like autism and genetic variants of autism, as well as neuropsychiatric disorders like schizophrenia. We're starting to get into some work in late life depression and also voice disorders. We have an ongoing program project grant looking at patients with spasmodic dysphonia or vocal tremor, and also patients with hearing loss and deafness. So these are some of the ongoing research projects that we're working on.
Well, thank you. Thanks very much. We're coming to the end of our session, so I really appreciate all your time, and thank you very much for being our guest today and for informing us about all the amazing work that's going on at UCSF and with MEG. So I really appreciate it. Thank you.
Thank you. Thank you. Excited to share this. Thank you. Bye-bye.